So these are the other dissociative disorder. We see common features of these dissociative disorders, okay, include dissociative amnesia, dissociative identity disorder, trance disorder, possession disorder, or depersonalization or realization. The common feature include the symptom result in significant distress or impairment in psychosocial functioning. Okay, this should be there. Okay, and the symptoms are not part of any known psychiatric disorders like schizophrenia or bipolar, or known neurological disorder, or as a result of any psychoactive substance. Sometimes this depersonalization reaction, derealization are common after cannabis. Okay, so we have to make sure that adolescent is not under the influence of any psychoactive substance, and we have to be very careful, especially if the adolescent is presenting with one of these dissociative fugue that is sometimes common after substances, depersonalization, derealization, because it can be due to psychoactive substance. So we have to rule out other psychiatric, medical and psychoactive substances. And it is very difficult to diagnose in young children, pre-adolescent children, because of the varied semiology, and they are not able to express their symptoms clearly. Okay, and usually it is misdiagnosed as development variation of their growing up. And cause, usually the onset of these dissociative disorders are acute, as I said in the dissociative neurological disorder, and it is usually occurs after traumatic life events or stressful life events like parental separation, physical abuse, sexual abuse, or parental loss, etc. And usually the onset may be immediately after the exposure to stress or after a significant delay. This has a poor prognosis. Okay, if the onset is very acute and immediately after stress, that the prognosis is good. If it occurs after the significant delay, it has a usual poor prognosis. Okay, although onset has been observed across lifespan, it is more common in young adult. Okay, usually in and around 20s is very common. Okay, in adolescent it is common, in young children it is rare. And course is very highly variable. Either it is a single episode or it is a recurrent. And in recurrent, the prognosis is usually poor. And it is usually highly comorbid with psychiatric disorders like depression, anxiety, personality disorders, or developmental disorder like autism and ADHD. Especially if they are high functioning, they have a higher risk of these dissociative disorders. Okay, so we saw about various dissociative disorders and what is the usual cause and outcome. Next, assessment and management we will see in common. Any assessment, a detailed psychiatric and developmental history. Here detailed psychiatry include presence of other psychiatric disorders like depression or anxiety symptoms, and evaluation of the current dissociative symptom, and evaluation and semiology. Okay, because this is very important part of assessment, because sometimes the organic conditions may be missed. Sometimes when you get a referral from the medical specialty like neurology or pediatrics, sometimes you may suspect, because they have diagnosed as functional, we need not agree always with the diagnosis. Okay, you have to get a detailed psychiatric history, especially evolution and semiology of the symptom, so that if it is correlating with any known medical or neurological disorder, we have to refer the patient back or get the second opinion to rule out any other underlying organic pathology. And developmental history include presence of any underlying development disorder like ADHD, ADHD or intellectual disability should be evaluated. Okay, so this include detailed psychiatric, that is evolution of the current symptom and semiology, and presence of any other psychiatric disorder and developmental disorder. This is the first part of assessment. Okay, and psychosocial, next is psychosocial circumstances and problems. This should be done, which is especially temporally correlating with the onset of dissociative disorder, because it is very helpful in the management. See, for the diagnosis of dissociative disorder, it is not required, but it is very important in the management. Psychosocial circumstances, what has preceded to the development of dissociative disorder, any family issues or school issue, peer bullying, victimization, any reduction in marks or poor academic performance, all these psychosocial circumstances has to be evaluated in detail. Next is child's temperament, because many a time the psychosocial situation may be less threatening, but the child's temperament will be very sensitive, and child would not have coped up with the less severe psychosocial stressor. Okay, child's temperament, family functioning, is there any maladaptive family functioning, or is there any issues in school? Those things has to be evaluated. And last but not least, a comprehensive medical, neurological, mental state examination should be done to rule out any other psychiatric or medical disorders. Okay, so these are the important part of assessment, a clear evolution on semiology of the dissociative disorder, other psychiatric disorder, developmental disorder, psychosocial circumstances, child's temperament and family functioning, and clear mental state examination and neurological examination. Assessment is continued. The diagnosis of dissociative disorder should not be merely based on absence of objective signs or physical or psychiatric disorders. Okay, if for example the child comes with loss of consciousness, since because there is no neurological or medical disorders explaining loss of consciousness, we need not diagnose dissociative disorder. The dissociative disorder should be made with the presence of any other clear indicator towards dissociation. Okay, so it is not the diagnosis of exclusion, and it is imperative to remember that the absence of physical findings applies universally to an earlier stage of development of all diseases. For example, here we are talking about any neurological condition or medical condition. It is very common to have absence of physical finding in the earliest stage. So, we should not jump in the diagnosis of dissociative disorder just because there is no physical finding. Okay, they may develop late also, and also physical finding that may appear non-relevant at first may appear significant later. Okay, so these things has to be kept in mind in the diagnosis of dissociative disorder. Usually the diagnosis of functional disorder, the diagnosis is made from the medical fraternity. Okay, so they have to diagnose, explain to the parents that it is non-organic, it appears psychological in nature. What psychological entity causes these dissociative symptoms is done by the psychiatrist. And again, when they refer with the diagnosis of functional disorder, the psychiatrist has to corroborate, okay, with his clinical skills, has to again redo the medical evaluation. It need not to be in detail, okay, basic medical evaluation that is recommended has to be done to corroborate with the physician's finding. Okay. So, again the diagnosis of dissociative disorder is not exclusion, as I was telling before. When the diagnosis of dissociative disorder is made with too much certainty without proper assessment, and physical or psychiatric disorders are often missed. Playing the devil's advocate, when the diagnosis is too tentative, okay, if we are not making a clear diagnosis of dissociative disorder, when we are supposed to, here multiple irrational medical evaluation is conducted and iatrogenic reinforcement of symptoms happens. Okay, they get attention for all the unwanted symptoms. It results in persistent of dissociative disorder, resulting in chronic dissociative disorder. Okay, so all these things has to be kept in mind while we do the assessment of children and adolescents with dissociative disorder. What are the common stressors which we have to bring in assessment? Temperament, okay, very anxious, harm avoidance, these are, and very sensitive and poor emotional regulation, okay, poor coping skills, difficult temperament leading to poor coping, okay, and borderline intellectual functioning. Why borderline? Why not intellectual disability? Because sometimes a mild intellectual disability, the symptoms, dissociative disorder symptoms are not very common. Mild, moderate, severe intellectual disability, they will not have that cognitive capacity for the symptom conversion. It is usually common in borderline intellectual functioning. Okay, they are not able to cope up, but they will have necessary cognitive functioning to be presenting as dissociative disorder. Okay, moderate, severe intellectual disability, it is definitely common, definitely not common. Mild, it sometimes can occur. Okay, and psychiatric and physical illness can lead to dissociative symptoms. Okay, so extreme psychiatric illness like depression, when it is not attended by the family, sometimes there is a child's way of conveying that I am having some problem and please help. Family related factors, critical or over involved parenting, both are common. Extremely critical or over involved and overprotective parenting style. Parental physical and psychiatric problem, mother is having some issues, example cancer, or parent is having psychiatric disorder leading to child neglect. Parental substance use, very common, result in abuse of the family members. Parental marital disharmony and poor communication with the child. Okay, and the child is not allowed to express the stressor, and it results in dissociative disorder. Environment, common or peer group problem, bullying in school, academic stress, harsh punitive school environment or abuse. Okay, so these are the common stressors presenting as dissociative disorder. Okay, so we talk about symptoms. What are the signs, okay, that is present in dissociative disorder? Okay, if one of these signs are elicited, is it 100% we can diagnose dissociative disorder? No. Okay, these signs are only supportive. Okay, like I told for EEG, these signs are supportive. The presence of signs, these signs, functional signs alone doesn't mean the child is having dissociative disorder. These signs can be taken as a supportive factors. Labelly indifference, when expressing symptoms, the child may smile or the emotions may be indifferent. Okay, discrete anesthetic patches, that is not correlating with the neuroanatomy. Okay, the child will have some anesthetic patches and it will involve multiple cranial nerve. At the same time, other parts supplied by the cranial nerves may be normal. Okay, discrete anesthetic patches. Ataxia, abasia, completely confusing walk. Sometimes it is normal, sometimes the child is having ataxia, sometimes the child may not stand. Okay, ataxia, abasia syndrome. Positive Hoover sign. Okay, what happens? Okay, for example, 2 legs, functional weakened. Okay, so this is left and right. The adolescent is having left leg weakness. When the physician keep the hands, okay, in the left leg and ask them to press down, they may not be able to press. Okay, but on the contrary, when they ask to raise the unaffected limb, right leg, against resistance, naturally they will press. You experience a tightness here. Okay, so this is positive Hoover sign. Okay, when the individual is having functional weakness, you can test for Hoover sign. When they are asked to press their heel against your hand, they may not be able to press with the affected limb. But when you ask to flex the hip of the unaffected limb, you experience clear pressure from the affected limb. Okay, this is Hoover sign. Okay, and preserved cough in the hysterical aphonia. The child is having aphonia, but the cough is normal. And hemianesthesia sharply demarcated in the midline. Okay, sometimes there will be a sensory overlap. It doesn't clearly demarcate in midline. When there is a clear demarcation, then it is possibly dissociative sensory loss. Hysterophrenic and hysterogenic areas. For example, when the child is having seizures, it is usually done as a part of suggestibility. If one area is pressed, okay, it results in control of seizures. And when we have a strong suggestion, I am going to do this maneuver and you are going to get seizure. One area is, for example, forehead, and press tightly and they develop seizure. Okay, these are hysterophrenic and hysterogenic areas in the body. Okay, when these functional signs are present, possibly we are dealing with the dissociative disorder. Again, these signs are not 100% conclusive of dissociative disorder. They are taken as a supportive finding. Okay, now we are coming to the treatment. So we saw what are the dissociative disorders, clinical features, then we saw about assessment and what is the treatment of dissociative disorders. Goals of the treatment. The first goal is towards symptom removal. Okay, the early treatment goal is to remove the symptom. Okay, long-term goal is resolution of stressor and prevention of further episodes. Okay, so these are the two parts. Usually what happens, many times the expectation from the medical community is to go for underlying conflicts. Okay, basically this is what is happening. Okay, in the mind there is a conflict. Okay, this conflict is converted into the symptom. Okay, why this conflict is converted into the symptom? Because this conflict is causing significant emotional response and our mind couldn't handle it, so it is converted into the physical symptom. Okay, in that way the conflict is not causing significant emotional trauma. Okay, so this is called primary gain. Okay, next what is happening? The family is giving too much attention to the symptom. The child is getting lots of perks for the symptom. Okay, what the child is getting due to symptoms, okay, is called secondary gain. If one or other family members are getting some gain due to the symptom, it is called tertiary gain. Okay, so here our first goal is to symptom removal. Okay, with appropriate handling and explanation to the family and the child, we have to aim for symptom removal. That is our first criteria. Then through psychotherapy, the finding out what is causing, whether it is only conflict or combination of temperamental factors, family related factors, environment related factors, along with the conflict leading to the symptoms. So all these things is the second goal in treatment as a part of psychotherapy intervention. Okay, so these are the goals of treatment in dissociative disorder. So the first step in the treatment is clear explanation. If we don't explain to the family about the nature of the condition, we will lose the patient. Okay, the patient will go for doctor shopping and the symptoms won't get resolved. It results in chronic dissociative disorder leading to significant morbidity. So this is the most important step. Sometimes this clear explanation alone will improve the condition. Okay. Here we have to clearly explain to the child and family, these are the real symptoms. Sometimes when you say psychological, they will think the child is lying, the adolescent is lying and they are cheating. So it should not be there. So we have to explain the symptoms are real. Okay. But the etiology is not physical, it is psychological. Okay. The symptoms are real. If there is a seizure, the seizures are real, but it is due to the psychological stress. Okay. And we have to reassure the family, even though the symptoms look scary, it is harmless. It is not going to harm the child. Okay, here the ruling out of organic condition is very important, and if the parents are raising doubts about this aspect, we have to refer back to the medical team and ask them to counsel them regarding harmless nature of the symptoms. Okay. Then once it is done, explain the mind-body relationship with example. For example, if there is anxiety, okay, a dog is coming to bite or they suddenly see a snake, they get palpitation, okay. So when they are becoming anxiety, so the anxiety is causing palpitation. Sometimes vasovagal syncope, when they have hearing a sudden bad news, they faint, okay. So all these things are examples to explain there is a relationship between mind and the body. The problem in mind can cause symptoms in the body. So these things has to be explained. Otherwise, the parents will think the person is lying. Okay, moment you say psychological, the model they believe is the child is lying or child is mimicking symptoms. So we have to explain mind-body relationship. And sometimes the stressor may not be important from the parents' perspective. They may not tell some stressor which they feel it is unimportant. Okay. Which they feel it is very important, they may not reveal, okay, but child, if you interview the child, they may feel those stressors are very important and child is very sensitive to it, okay. So the importance of stressor from the child's perspective has to be educated to the parents, okay. So these are the explanation that has to be given in the initial phase of treatment, without which the treatment will not progress properly, okay. The next is behavioral strategies to control the symptoms. Okay, we will explore the stressor, we will improve the coping later, but what should we do to control the symptoms? So these are the steps. Reassuring the child. Sometimes the child having lots of anxiety towards the symptoms, okay, because it is assumed it is involuntary, okay, and we have to strongly encourage the child to return to normal functioning. Yes, there are symptoms, but start schooling, start studying. If the symptoms comes, it's okay. Okay, once they are returning to the normal functioning, that itself will cause lots of symptom remission. Encouraging physical activity and relaxation training with a strong suggestion that these activities, okay, improve psychological well-being so that symptoms resolves. Okay, so these are the activities which there is clear evidence to improve the psychological well-being, which results in the symptom remission. Okay, involving in other interested activity. If the child is not able to completely return to the normal functioning, involving in other productive activities like drawing, coloring, music, whichever the child likes, or interaction with the family members, instead of sticking with gadgets. Most often what happens in child with the dissociative disorder, they will not be able to function, so they start using gadgets, they start using mobile phone, so that becomes a significant secondary gain. So dissociative disorder will become at some point will become factitious disorder where they will start feigning symptoms. So involving in other interested activities and encouraging physical activity and return to normal functioning is very important of symptom control. And differential reinforcement. Okay, differential reinforcement is we are going to ignore the symptoms, but at the same time give importance to the well-being. Okay, when our adolescent is doing well or return to the normal functioning or involving in physical activity or they are involving in relaxation exercise or involving in other activity, they have to be strongly reinforced. Okay, they have to be appreciated. But when they have symptom, we have to subtly reinforce. Ignore means we should not scold, we should not shout, like we should not give too much importance. Okay, we should not crowd around. Okay, we should not discuss about the symptom with extended family members. All those things are giving attention to the symptoms. So we should avoid those things and focus on well-being. Secondary gain, any excess perks that is associated with the dissociative symptom. For example, if they are staying at home, giving excess TV or excess mobile is secondary gain. So, we have to avoid secondary gain. Okay, differentially reinforce the well-being and ignore the symptom. Okay, these are the behavioral strategies. If properly implemented, it results in quick control of symptoms. Okay. Once the symptoms are controlled, sometimes it leads to symptom substitution. Sometimes one dissociative disorder may become another dissociative disorder. For example, dissociative neurological disorder may become dissociative personality disorder, identity disorder. Okay, or sometimes it results in deliberate self-harm. Okay, once they are not able to, the primary gain is not happening here. The conflict is not converted into medical symptoms. So, the conflict is directly causing depression, resulting in deliberate self-harm. Okay. So, we have to be very careful when there is a symptom resolution, or sometimes it can result in aggressive behavior. They may harm others or histrionic behavior, highly aggressive, and they may develop clear depression. Okay. So, once there is a symptom remission, we can expect these things. Okay. Here, at least the clarity is there. We are not going to chase begin any medical diagnosis. Okay. Here we know it is a psychological problem, and here the treatment is appropriate psychotherapy and pharmacotherapy directing the underlying psychological problems. So, here at least there is a clear path to the treatment, so that patient won't doctor shopping and parents won't be confused. So, they have understood it is clearly psychological in nature and it is little easier to deal with rather than expressing as a physical symptom. Okay. So, this is symptom substitution. Then, once the symptoms are controlled, as I told, the psychotherapies. Okay. Starting from simple supportive psychotherapy, being empathetically listening and supporting the child, cognitive behavior therapy, that is working with the maladaptive cognitions of the child, interpersonal, improving the interpersonal functioning of the child, interpersonal psychotherapy. If you are suspecting personality disorder like borderline, dialectical behavior therapy, psychoanalytic psychotherapy. This is not that commonly used because it is very intense and prolonged psychotherapy techniques. Previously, it is the treatment of choice for dissociative disorder. Nowadays, nobody is focusing only on psychoanalytical therapy. It is mostly eclectic therapy, a combined approach whichever is useful to that particular clinical scenario. Okay. Previously, the psychoanalytical therapy or the treatment of choice for dissociative disorder. And if you suspect the entire family is having the dysfunction, there is a clear family pathology, the family therapies are all indicated. So, psychotherapies is for long term. It is not to control symptoms. Only supportive therapy can be used to control symptoms, and to an extent CBT can be used to control symptoms in altering the maladaptive thoughts. Other things are for a long term in improving the stress coping and managing the stress and improving the family communication and functioning and prevent further episodes. So, psychotherapies are for long term. So, CBT is very commonly used. So, this we briefly see what is the overview of CBT. So, give positive explanation to the symptoms. Sometimes the adolescents or children will have guilt about their symptoms. So, give positive explanation. Persuade the child, motivate the child that change is possible and she is not broken or damaged, because they will have this thing, everybody is looking at me like I have wasted the money and I have lied, I have cheated. So, explain to the child the change is possible and he is not broken. Okay. And there is a good potential to recover. And as I was telling, encourage, as a part of CBT, encourage engagement in daily routine. Okay, sometimes it may be graded switch to the daily routine, but encourage a daily routine. That should be a routine. And teach relaxation and distraction from unpleasant thoughts and symptoms. We call it as grounding. When they have unpleasant thoughts, most often the symptoms are noticed. Okay, and we have to encourage them to identify is there any abnormal thought or cognitive error. Okay, we commonly call that. Once they have these symptoms or unwanted thought, we tell them to distract, do something else, or grounding. Okay, do relaxation exercise or feel around the environment, so that there is a distraction strategies from the unwanted symptoms and thoughts, or sometimes even unwanted emotions. And encourage the patient to rationally reconsider unhelpful and negative thoughts. Once they have overcome that phase, we need not do reframing during that time. Okay, that time they will be overwhelmed, and sometimes they may require to relax, they may require to distract themselves, and later on rationally reconsider, means reframing. Okay, I am useless, I am worthless, these things am I really useless? Okay, what are my friends telling about me? Okay, and what have I achieved before? Okay, is it like 100% true that I am useless? No, this is what rationally reconsidering unhelpful negative thoughts. Okay, and negotiate if they cannot return to the complete functioning, phased return. Okay, graded return to the work or studies. And joint activity with family members, if the family is involving with them, okay, during the symptom free period and they are ignoring symptoms, that results in good outcome. Okay, so these are the steps that is generally followed in CBT in dealing with dissociative disorders. And when is hospitalization required? Sometimes the symptoms, even though it is harmless, it looks very scary for the family. Okay, and hospitalization is considered when there is a doubt about diagnosis. Okay, there is a suspected pseudo seizure, but we are not sure. So we admit, observe, and if it is clearly pseudo seizure, manage. Severe symptoms, when the symptoms are polysymptomatic and very severe and there is a clear confusion, probably admission is suggested. And family is very distressed and couldn't ignore or couldn't reduce secondary gain, then probably consider admission. And the symptoms are resistant to outpatient treatment. It's a chronic dissociative disorder, then probably consider IP treatment. Okay, IP treatment, the protocol is same, but here when they are inpatient, the family is able to cope better. Okay. Thank you.